You found us, episode 6 of Children's Pedcast, a conversation about pediatrics with children's hospitals and clinics of Minnesota. I'm Jimmy Bellamy. Today's guest is Dr. Maurice Sholas, our Senior Medical Director of Rehab Services. As of this recording, Dr. Sholas has been at Children's a little over a month. He will talk about his experience as a healthcare professional in New Orleans, Atlanta, and he'll share his vision for Children's and the Minneapolis-St. Paul medical community as a whole. Dr. Sholas is a physiatrist, and when I first heard that word, I thought, do you mean psychiatrist, physiologist? Physiatrist. Other than being fun to say, it's also a rehab physician. Dr. Sholas talks about how what he and his colleagues do, it's connected to every area of care at a hospital. So he will see patients who are dealing with cancer, kids who have suffered burns, kids who have suffered spinal cord and brain injuries, kids who have encephalitis, kids who have cerebral palsy. He deals with a lot of different patients, and he is all about making kids better. From start to finish, he wants to find the way to make kids better. And it was great to talk to him about how all of that is tied into every area of care. You can find us on social media, and you can also find Dr. Sholas on social media. It's neat anytime someone comes in here as a nurse practitioner, a doctor, to know that they are active on social media. I like that. It helps make my job easier. And my goal is to make Children's and our myriad experts representatives online on social media so that they can share their knowledge and experience with everyone, not just the people who come in here day in and day out. So enjoy this episode. You can find us at childrensmn.org. We're on Twitter at childrensmn. Maurice Sholas is at DocMoShow on Twitter and Instagram. That's DocMoSho. Very cool Twitter handle. And enjoy the show. Appreciate you doing this.
No problem. This thing live?
Yeah, we're live. we're live in air quotes.
In air quotes.
This has been edited, not for censorship, of course, but people are listening to this days after we recorded. And, I have to thank you again. We went to lunch last week. Of course, the audience couldn't go with us, but that was a good lunch.
Great lunch.
Yeah,
Great lunch. And it's nice when good minds get together and talk about innovation. That's one of the things I'm here for, is to innovate. And you and I are definitely on the same page with that sort of stuff.
I've never thought of myself as a good mind. Tell that to my parents. Tell that to my wife.
Hopefully we'll package this up and send this to your wife and your parents, and they'll be able to check a notch off to say, yes, it's been independently verified. Jimmy Bellamy is a great mind and a great thinker.
And this will live forever on the internet, so
it will.
That's a good thing for me.
It will.
Awesome. So welcome to Children's. You've been here now a little over a month.
Correct. My 1 month anniversary was on the 2nd.
And did it fly by?
It really did fly by. I mean, I've gotten the warmest, most wonderful Minnesota welcome one could ever hope for, especially for a guy like me that comes in as an agent of change. A lot of times when a change agent comes to bear, people think of all the worst and fill in the blanks with all kinds of terrible stuff. So sometimes they're not so nice, but the Minnesota nice has really won out, and people have just been tremendous at opening up their minds and the possibility that rehab services can grow and live and thrive here at Children's in Minnesota.
And you probably are happy that there was something warm about coming to Minnesota.
Yes, it looks like I brought a little bit of good weather with me from New Orleans. The weather, apparently by all Minnesotan qualities, has been unusually warm this time of year. My allergies kicked up this morning, so I can attest to that. So if that's what it takes to keep this southerner alive up here this far north, I'll take it.
And allergies are the truest sign of spring in my book. It's not what the groundhog decides to do. Punxsutawney Phil doesn't have anything on allergies.
Absolutely.
So tell me about physiatry and rehab services and everything going on. I mean, there's so much going on, whether it was our conversation at lunch or our meeting the week before. There is certainly not just one focus in your line of work. How do you keep everything straight?
Well, first of all, I guess we start with definitions. Right now, in this system, when people say rehab services, they're typically talking about therapists, physical therapists, occupational therapists, speech pathologists, audiologists, and such, and the services they provide children to help make them more functional. When I speak of rehab services, I'm really looking to expand that definition to include physicians. And rehab physicians are called physiatrists or PM&R docs. And specifically, PM&R docs that deal with kids are pediatric rehab, peds PM&R, all those things mean the same thing. A board certification handed out by the American Board of Medical Specialties certifying that people are doctors of function, especially as that relates to kids.
This is so far removed from what you do when it comes to my jobs here at Children's, but we have one thing in common, which is we work with a number of different areas of the hospital and the clinics. That has to be fun when you can tell people your job is different every day.
Correct. Rehab is really the glue that holds together care for complex children. So physiatrists or rehab docs can work with cardiologists at helping kids become more functional after they've had their heart surgery or their near-death experience. Rehab docs can work with oncologists or cancer patients, helping them get strong and prepare for chemotherapy or prepare to fight their cancer battles or to get back to rights after they've successfully defeated cancer. We can work with children that have acquired problems like brain injury and spinal cord injury. We can also work with kids with congenital issues like early birth leading to cerebral palsy or spina bifida or limb deficiency. So our job is really to say, whatever you come with, how can we make you as functional and as happy and as integrated in life as possible?
At what point does rehab services enter the conversation? Is it individually based, or is it this child is experiencing this kind of symptoms or this kind of illness, therefore we'll bring rehab services in at this point every single time? Or how are you, when do you enter the conversation?
Excellent. I typically first meet my patients with acquired physical disabilities in the intensive care unit setting. So I like to say to myself and to my patients and their families that we are harbingers of good things to come. They don't call rehab to see a patient in the intensive care unit unless they're expecting there to be some sort of pivot towards better. So I bring good news and good tidings. Other situations, I meet patients for the first time as an outpatient. They've been moving through life and they've been doing well or they've been doing not so well, and they need to talk with someone that sees them as not just a constellation of different symptoms or a list of names on a piece of paper, but a whole kid that happens to have some stuff going on with them that makes it a little challenging for them to be typical. So I'm happy to meet people for the first time in the intensive care unit. I'm happy to meet them for the first time in my office. And I'm happy to meet them wherever I find them. That's the beauty and the balance of rehab.
And how many people are in your department? Because we have so many kids on a day-to-day basis, some short-term, some long-term. How are you able to balance that, or is it just you get to what you can?
Well, right now we have a pretty extensive therapy service section. Right now we have quite a few therapists, both physical, occupational, and speech therapists, as well as audiologists spread out through the system at the Minneapolis campus and the St. Paul campus. But we also have satellite campuses all over the region, including Maple Grove. There's satellite campuses down at Minnetonka, just to name a few. So really the breadth of rehab services really covers the breadth of the Twin Cities area. Now, as far as what physician support we have, my colleagues at Gillette are fantastic. They've been providing wonderful services for kids with acquired and congenital physical disabilities. And now it's time for us at Children's to step up and support that role by having viable physician services available on par with the extensive and wonderful therapy services that are already existing in our system.
We are at a point of a lot of change. You mentioned innovation in your conversation at the start, and you talk about your vision and about having that whole care experience where from start to finish, kids can get the care they need here. Now, recently we had the arrival of a new CEO. There's a lot of change going on at Children's,
Yes.
and in the short time I've been here, I've noticed that too, that it's ever changing, and really any place that you want to be successful, that you want that in. You don't want to be afraid of change. You don't want to be stagnant.
Correct.
what kinds of things have you been doing in your month plus here, and what do you see for the care for kids in the Twin Cities metro area?
Perfect. Well, this is really springtime for children's. We talked about the allergy season, saying it's physically springtime here in terms of season, but this is really the rebirth of spring for children's here in Minnesota. I say that for a couple of reasons. Number one, the CEO is new, and he's bringing a new set of eyes and a new vision and a new mandate to our system. I'm new to the system, and so some of the older problems we've been looking at, how do we provide services for kids? How do we increase access? How to increase our pipeline? How do we make sure our services are world-class and innovative and bold compared to everywhere else? That's what people like me were brought here to do. There's a different skill set that it takes to run a program that already exists than what it takes to actually create one from scratch, and creating one that actually meets the needs of the community. So what to look forward to? Number one, lots and lots of conversations. My first order of business was sitting down with my colleagues and understanding what do they need and what do they want. Number two, more conversation. I'm going to sit down with patients, parents, and understand from their perspective what's worked so far and what hasn't worked so far. And then use that information to make sound, appropriate recommendation to the larger body. For example, the experience here of a kid with a disability is number one related to the physician they see, but it's also related to those wonderful nurses that provide care. It's related to the therapists that touch them and help them be more functional, but it's also related to our physical plant. How easy is it for our patients to get here on public transportation? Is there a stop close or not? How easy is it for our patients to drive in and get out of their cars if they drove and leave their cars behind and step forward with their appointment? How easy is it for our patients to be here, be able to get onto and off of the examining room table without injuring our staff that have to assist them in the process, so they truly feel like they weren't an afterthought, but they were actually part of the planning of the facility. So what my job in terms of innovation here is to do is not limited just to physical talents or physician talents or nursing talents, but it's really to look at what sort of experience do kids with disabilities and their families have when they come here, and how can we make that the best possible so we can focus on them, the road to better.
I can't think of a better person to be in your position, because you are looking through a set of eyes that is constantly seeing care in a variety of places. You frequently go back to New Orleans. You spend time in Atlanta, and you can share with our audience the work you do there. Mm-hmm. So it's nice to have someone coming in with this ongoing experience where you can see what is working in other places, as opposed to me who often is office bound, or maybe on one campus more than another. Mm-hmm. And you get used to seeing things a certain way, where your environment is different on a regular basis, and you can almost pull from the best of every area.
Exactly. I like to say to people that my clinical job as a pediatric rehab doc is very similar to my administrative job as a program starter. In rehab, I help make kids as functional as possible based on whatever they bring to the table. Administratively, I help make programs as functional as possible based on what they need, they want, and what they can do. And to do something like that, you really have to explode the box. You have to understand what are best practices other places. What does it look like to deal with a 4-floor walk-up in New York City versus a big flat ranch house in Texas in terms of getting in and out? What does it look like to manage a kid with burns in the deep south where it's very hot and you don't sweat very well when you have burns, versus what is it like to manage that same kid in the north where it's really snowy and dry? So although you don't have to worry about sweating, you do have to worry about super dry skin, cracking, and being irritated during your very harsh winters. So it's about not just doing a job, but pulling from different places and parts to understand how to do the best job you can wherever you are.
When it comes to medicine in general, how often, right? Not how often, I guess, but for so long, was this the case that unilaterally things would be put into place, and they would say, this is how you treat this? And really, it seems to be the opposite of your thinking, where you need to take into account the infrastructure of a place, the geography of a place. So much is involved in that care. It makes it feel more specialized than care typically is thought to be.
Absolutely. As a physician of function, our job is not just to look at what the problem is or what we call it. We need to look at making a solution that comes in a context that's relevant and meaningful. So something that's relevant and meaningful in Minnesota may be very, very different than something relevant and meaningful in New Orleans. You brought up that fact that I am a New Orleanian, and people in Minnesota go to parades and they think it's great. Well, in New Orleans, when we go to parades, you don't just get waves back. You actually get loot and booty and things thrown. And I think if you take a New Orleanian and put them in a setting where they went to a parade where they didn't get anything, they'd say, wow, that was a beautiful float, but what was the point? How did that work out? And the needs of that particular person, that individual, weren't met because of the context.
They need that interaction.
Yes.
They need that prize.
Yes, you need that prize. You got to get a reward for being there. And I think similarly in medicine, we are moving towards a place where we say, I don't just have a name for what you have, and I don't just have a protocol to treat what you need. I have a name for it and a protocol that works for you as opposed to for a group of people. That type of personalized touch makes compliance better. It makes the patient and physician connection better. And it really is the essence of patient and family-centered care. That's important to me.
How about the result that you get with an individual case? How often is that shaping what you're implementing in future cases?
Experience matters. And I like to say to people all the time, I'm not smarter than everybody else in terms of program building. It's just I like to feel like I've made all the mistakes in the past and learned from what I've done to know what to do going forward. So I'm really excited about that. I'm really excited to say to a person that came to me not knowing what their path forward would look like. You don't know what better looks like when you're sitting there in your bed after something catastrophic has happened. You don't know what better looks like after you've had a child that's not typical and you don't know where to go. I have the privilege of working with those patients and families to help them chart their path forward. And that is so tremendously wonderful and inspiring. It's so tremendous to be able to say to somebody, you aren't the only person that's ever had this happen. And I've known somebody that came out the other side feeling great and smiling. Let's see how we can get there with you too.
Everybody seems to be at a different point in the trust process when coming in. Often when people are at a hospital, they're enduring one of, if not the most difficult circumstances of their lives or
Absolutely.
their child's life.
Absolutely.
How are you able to gain that trust of a patient and a patient family to let them know and reassure them, here is what is possible. It may not look like that now, but I promise you it's possible to get there.
Absolutely. Great question. It all starts with the evolution of how we actually practice medicine as doctors and how other paramedical and other professional support services come to bear. I say that because in the old days, medicine was very paternalistic. A person or a patient or their family came in and said, Doc, what do I have and what should I do? And the doctor would be very prescriptive in saying, these are the list of things that need to happen. I need to do them this way or else it's not going to work out for you. I think that has evolved to a point where we still recognize physicians and medical professionals as thought leaders. We recognize them as having specific and special talents. But the interaction with patients and families is more like a conversation to understand what is the context under which you come to me, culturally, ethnically, socially. For example, the way a Native American person or a Hmong person or a Black person or an Asian person or any of these different groups look at death, dying, and illness may be different. So the words we use to connect with them and the process and mannerisms in which we employ and utilize our treatments need to be different for them to resonate and be real to the person we're talking to. You don't get that unless you understand who you're dealing with. You don't get that unless there's a conversation and a partnership between the medical staff and the family. Because the one thing I learned a long time ago is you may be an expert in medicine, but there's nobody that's an expert in that kid like a mom or a daddy.
And that's the truth. And that's what I've seen across the board at Children's is the respect that is obviously key in providing a family that you understand. Parents are going to know their children better than anyone else. And in order to form that partnership between the care team, or between the doctor and the family, to create part of that care team, that trust has to be there and that respect has to be there.
Yep.
Immediately.
Absolutely.
And I think Children's does a wonderful job of being able to do that. We talk about you having a hand in every area of care here at Children's, in every department. What are some of the things you most commonly see kids dealing with here where rehab services comes in to play?
Okay. The children that are most likely to need the most amount of support from someone like me and the services that I'm leading are kids with catastrophic or really complicated medical issues that impact their function, their independence, and their health. So kids with cerebral palsy are a good example. Kids with spina bifida, kids with traumatic brain injuries, kids with spinal cord injuries, so they're paralyzed, kids with missing or atypical limbs, kids with burns, children that are not able to be conditioned and run and jump and play typically because they have underlying heart disease or lung disease, children that were born without complete functions and abilities that a typical child would have. All those children require an intersection between the diagnosis they have, the supports they need to move forward, and the function that they'll ultimately be able to develop. We, as a physician of function, look at kids as a kid first and diseases second.
We've been fortunate in the I think little over 3 months, or a little under 3 months that we've been doing this podcast.
Yes.
We've had listeners from all over the United States and all over the world listen to us.
Absolutely.
If a parent is listening right now and they know that they are going to be in need of these services, or not that you would ever want to face this if you haven't, but in the future, if a parent needs help finding out what kind of services are available to them in their area, what are some things generally that they can do, of course, with not knowing what every area of the United States is set up for?
Well, you can. That's a great question. What are resources out there you can look at? And I would tell people to go look at the American Board of Physical Medicine and Rehab and look under the section of Physical Medicine Rehab for Children or Pediatric Rehab. It'll give you a list of every single person in the United States and Canada that is board certified in pediatric rehab. It'll give you their address and their contact information so you can look and see how close one of those specialists are to your community. It's the first place. The second place you can go are different parent advocacy groups. There's wonderful advocacy groups out there like Reaching for the Stars. A good friend of mine, Cindy, started in the metro Atlanta area, but they really are providing parent-centric and parent-perspective resources to kids that have cerebral palsy all over the country. So there's lots of things out there. If you want to find me and ask me questions, my address on the email is maurice.sholas. That's maurice.sholas at children's, with an S on the M, end, nm.org. Maurice.sholas at children's mn.org. I also have a website.
Yeah, tell us about the website.
The website, www.docmosho.com. DOCMOSHO. That's also my Twitter handle. That's also my Instagram page and my Facebook page. And both Instagram, Twitter, and Facebook are really devoted to people that want to catch up with me and ask me clinical questions or ask me what I think about some stuff. So that's out there as a resource, because what's the purpose of having knowledge if you don't share it?
You caught my eye right away because of your social media presence. And this is what I've wanted out of a lot of our staff. And I think eventually we will get there where every department has at least a representative active on social media, in finding out that it benefits the organization, the hospital as a health system. It benefits the docs, the nurse practitioners, and everyone, and it benefits the community, because our world is so small. You're able to see firsthand the connections that we all can make through social media, and you as a doctor have done it. I'm sure we could sit here for hours talking about how that has benefited you, or experiences you've had because of being on social media. How important is implementing, whether it's innovation or it's just that social interaction that you're able to provide, where a decade plus ago maybe it wasn't as possible as it is now?
Yes, I have never felt as old as when I was attempting to learn social media as a platform for the first time. It wasn't something I grew up with, and it wasn't something I knew how to use for anything other than laughing at old throwback pictures from my friends. But thanks to three great ladies, Angelique, Anissa, and Malika, those three ladies really sat down with me and walked me through the process and got me started. Secondly, I think my attitude of saying I don't mind messing it up a few times if it means me ultimately getting it right served me well. And the third thing is that really through trying new things and learning new things and growing in new directions, we keep ourselves young and alive. So I don't have a bunch of followers on Twitter, but the ones I have are fantastic, and they help me learn every day.
You will after this show, I guarantee it. We'll make sure. And you hit it on the head. That's the only way you learn, just like in anything, is by practice and doing it. And no one would expect. I remember when I first joined Twitter back in late 08, early 09.
Yeah, and you were 5 years old at the time.
I was 5. I was 5. I just started shaving. And I remember looking at other people's tweets to figure out what the lingo was, what the different characters meant. So what did RT mean? And you, at first, you look at it and it's like reading a map in another language. You have no idea what anything means. But that's how you learn, is you just continue to use it over and over and practice with it. And anyone, whether you're a parent or you are somebody working in the healthcare industry, and you find social media has a lot of barriers because you're unfamiliar with it, or you may be intimidated because there are so many channels to choose from. What do I do? Do I have to be on Facebook? Do I have to be on Twitter and Instagram and everything? You don't have to be on everything, and
you don't have to be on everything, and do baby steps and rely on help. I'm really great at medicine. I'm great at program building. I was not intrinsically great at social media connection, so I found someone to help me. And sometimes that someone is much younger than you. Sometimes that someone is much more experienced than you, but they'll help you. That's the first. And the second thing is that in medicine, we tend to be very conservative about everything. We were really slow to adopt electronic documentation. We've been slow to adopt electronic medication prescription processes. We've been slow to adopt electronic verifications of credentials as we put things together. And I think social media represents another frontier that we're slow to move towards. And there's good reasons for that. I mean, like bankers, we have to be very careful to protect people's privacy and protect people's information. But we also have to find a way to speak to people in a language that resonates with them. We have to find a way to get the gospel of rehab pushed out there in whatever medium finds those that need help. It's not for me to say to someone, because I don't speak to you on a platform you use often, you don't get services. That's not fair. It's for me as a person that has special or unique services. It's for me to go out there and engage the public in ways that are safe, responsible, and socially accessible to help people know where to go and where to be.
That's a good point, because there are so many people. I think we forget that we assume everyone is on social media, and I have several people in my everyday life who aren't on it, and it's funny how we've now reached this point, and certainly it might be generational. Sometimes I don't know where I lie. I feel like I have one foot in the 20th century and another foot in the 21st, and it's weird because I've experienced, I know what it's like to have to wind your hand to roll down a car window, where a kid now would ask, "What are you doing?"
What is that?
You would have no idea what that is, or manually locking a car door.
Hey, I predate ATM machines and cell phones. So when I grew up, you had to get all the money you needed for the weekend out on Friday before the banks closed, or you couldn't get any cash.
And for me, ATM ATM machines just appeared. I don't know when they started. When did they even start?
So I started college in, oh gosh, you're making me say numbers on air.
Oh, come on. You're not nearly as old as you think. I promise you. People
I
would be like, oh, he's young.
In 1987. And in 87 was the first time I remember having an ATM card, and it only worked at a couple banks. So right around the late 80s was when people started transitioning from writing checks to cash themselves to actually being able to use ATMs.
I was actually 5 years old in 1987. I turned 6 in September of 1987. It was a good year. The Twins won the World Series that year.
Oh, yes. And it was a good year. The first year, the Reign of Terror of Me was released on College Life.
Oh, I can imagine. Where did you attend school?
I went to Southern University in Baton Rouge, Louisiana, so I'm a proud Jaguar.
That had to be a fun experience.
Oh, my gosh. Football season in SWAC schools is something to behold, and there's nothing better than us, our band, blowing out those bums from Grambling in the Bayou Classic. I'll also, while I'm at it, I'll make sure all the rest of those SWAC schools, Jackson State and Alcorn and Texas Southern and Prairie View, all know that our band is still the best in the land, and we're often imitated, never duplicated. But let's get back to medicine, because I could talk about football all day.
I was going to say bands and football, it's so different than the Big Ten.
Mm-hmm.
And of course, Ohio State has a proud band, but football, whether it's SEC or just in the southern part of the United States, it's night and day compared to here, where especially the high school football here. The high school football, I'm sure there are some terrific teams, but where I come from in Duluth, it's run, very little passing. And then even you get here into the metro, there's more passing, where you do see some college-ready players. But football in the South, I'd love to go to a college football game somewhere in the South, because it's an experience I hear.
Oh, yeah.
And from what I've seen on TV, which I'm sure does not do justice to being there in person.
Oh, my good
something
friends
I need to experience.
They go to Death Valley there at Tiger Stadium when LSU is playing in Baton Rouge. That's quite something. My grandmother lived, when she was alive, not too far from that stadium. We could hear it from the house. Football is an experience. Now, I'd be remiss if I didn't say my good friends in Texas, California, and Florida didn't have great developmental supportive programs for athletics, football specifically, because I think football is religion in Texas, if I'm not mistaken.
I think football is to Texas as hockey is to Minnesota.
Oh, my goodness. Very good.
At that high school level, I mean, you hear stories about 10,000 plus seat stadiums full for a high school football game on a Friday night in Texas.
Wow.
And then we have our state hockey tournament here. The boys' state hockey tournament, I think, consistently sells out its 18,000 seat arena where the Wild play in St. Paul.
Now, you know what's interesting? We're talking about sports, and I think a lot of times people think when kids have disabilities that precludes them from playing anything but recreational sport, or sports that are just everybody gets a trophy and everybody gets a hug at the end. But I want to be here to say that competitive level athletics are available to all kinds of athletes at all kinds of levels. And if you don't believe me, type Paralympics into any search engine browser and see what comes up, and you will see world-class superstars with all kinds of things that make them atypical, but still very, very competitive. So as a rehab doc, again, one of my goals is to make people understand and know that no matter what hand has been dealt to you, we can play that poker tournament and we can still do the best we can at winning. And a lot of times, you don't need all the aces. You just need more than everybody else.
Absolutely. You hit it on the head with the Paralympics and with the adaptive high school sports in Minnesota. People of all abilities are able to participate. Have you had experiences where a child has come in and gone through rehab services and then realized that he or she is able to go do something that maybe once wasn't the case?
You know what's interesting? The best story I have for that was when I was a resident. I was a resident in San Antonio, Texas, University of Texas Health Science Center. And one of my patients got injured by a gunshot and it left him a paraplegic. Prior to that, he had not finished high school. He was doing things to mark time, but not really much productive for himself or his community. After his injury, he really had a chance to focus on his academics and focus on himself. And he transformed. He went and got a GED, ultimately pursued college courses, and became an elite level wheelchair athlete, actually crushing road races all over the place. And so I never wish an injury on anyone that would make them have to become my patient. But it's so beautiful to see people find themselves in the face of tragedy and find their footing when, ironically, this guy lost his ability to stand.
That has to be one of the most rewarding parts of your job, where you take a child who maybe doesn't think he or she can achieve a certain level of success or ability, and then through the work that you're doing, he or she is able to see what is possible and make it happen.
Correct, and make it happen. As a physician, I get to be a catalyst and a conduit. I've had expertise in medicine, pharmacology. I have great friends that are therapists that help me do the things I need to do to help children be functional. I have other great friends that are prosthetists and orthotists that help make braces and prosthetics that help people replace or make better things that aren't working perfectly. I have colleagues that make durable medical equipment, but I also have stories. I have families. I have communities. I have people that know what it's like not just to empathize, but sympathize because they've been there. And that's the beauty of rehab. We see and interpret medicine through the lens of real life. We see and interpret the process of finding better through the context of real life.
One thing that stands out to me, too, in this area of medicine is there's no end. It's not all right, you're good, you go home, it's over.
Correct.
You're constantly, whether you're following their progress indirectly or you're learning about, you do one area of treatment and then you want to know, well, how will it be months from now, years from now? It seems like it's something that's never ending, and a lot of these patients are applying it to their everyday lives.
Absolutely. I've said to myself, the best thing I did to improve my grasp of English, grammar, and language was learning Spanish. It's very difficult to learn a second language if you don't take the time to understand the structure and grammar that goes into your primary language and how that translates over. So I'm proud to be bilingual, and I'm proud that being bilingual has helped me understand my own language and culture better. Similarly, our patients that are moving through whatever challenge they're moving through, functionally, physically, spiritually, emotionally, find that the skills it takes to move through their biggest challenge are also applicable a lot of other places. And so you'll find people, as they blossom in one area, really open up other areas in their lives. And that's just, it's tremendous. It's just like once it gets going, it just can't stop.
When did you realize that you had the confidence to say you were bilingual, as far as, okay, I know this? I mean, I took Spanish in high school, and I learned more Spanish from a gentleman who was born in Venezuela, working with him for a few years. Within a week of working with him, I learned more Spanish than I did in 2 years of high school. And that's not to be disrespectful to my high school teachers. It may have had something to do with my attention level at the time.
Yes.
But when did you feel that, okay, I'm comfortable enough where I feel I'm fluent with this language?
When I started dreaming in Spanish. That's what I knew it was okay. The other thing, though, is that when you're learning a language, you have to be fearless. You have to be willing to say something and mess it up. Like the word for dresser and the word for testicles are very similar. And I attempted to unpack my clothes into the testicles as an error when I was learning Spanish. And you have to be willing to make those kinds of mistakes and get laughed at and move through them. The second thing is you have to always be willing to know that there will be somebody out there better than you, and there'll be somewhere up you can still go. So I still do practice now. I have Duolingo on my phone, and I practice Spanish when I don't have anybody to talk to, so I can kind of keep my skills sharp. And I still get super nervous when I have to present things professionally or formally in Spanish, because in the back of my mind, I'm thinking, oh my gosh, am I up here sounding like a 5-year-old presenting concept in medicine? I'm doing great at a grocery store, ordering at a restaurant, but to talk about truly intellectual, smart things, do I sound like a child trying to talk to adults? So there's always something to keep going. There is, like rehab, there's never an end.
We have an incredible interpreter services program here.
We do.
Have you had conversations in Spanish with any of our interpretive services people?
Very briefly, but I look forward to more conversations. I will tell you that even though I'm very comfortable with my Spanish, in difficult decisions, I still use interpreter services because you want to communicate, and you want to communicate as best you can.
Absolutely.
And you don't want your word choice to get in the way of someone's understanding. So it could be that I'm speaking a version of Spanish that's indigenous to one area, and the word choice that they use in another area is very, very different. And so that would be a barrier, even though we were both speaking the same language. I think interpreter services really helps minimize some of that and helps make sure that what you're pitching is what they're catching.
And that's crucial and critical to our line of work because of the information that is being shared. You have to make sure one word could do it, and it could make or break it. So that's a good point. I keep thinking about all of the areas that rehab services touches in the hospital, and we talked about physical medicine and rehabilitation, PMR for short, of course. What would you say its main function is in interacting with other areas around the hospital, or is it different depending on the area?
It's the same. It's just the context is slightly different. So we are physicians of function, and my job and the job of my colleagues is to help people deal with the consequences of disability. So if that disability is just a few weeks long, the plan is going to be different than if your disability is for a lifetime. The plan is going to be different for disability that causes very mild changes to function versus those that cause catastrophic changes. But no matter where we are, we're still physicians of function trying to deal with the consequences of whatever disability. For example, you have a brain injury. I can't go and undo your brain injury per se, but I can use medication to help you with your cognitive skills and your ability to focus and attend to stuff. I can use medication to help even out your muscle spasticity so you can focus on using your strength and coordination to do functional tasks. So I'm not fixing or removing the fact you had a brain injury, but I am managing the consequences of that brain injury.
Is the brain the area of rehab where you're learning more each time? Because there seems to be so much that's unknown about the brain. I guess, is that where you're getting the most surprises in some of the applications?
Yes and no. I think the brain is sexy. A lot of people are excited about studying
Nerds
it.
everywhere got super excited when you said that.
It's
true, though. It's true.
Sexy.
And that's the thing is, if any high school students are listening right now, once you get out of high school, the brain always matters, but the brain really matters after high school.
So there's a lot of things going on there. Like if we look at anti-NMDA receptor encephalitis, it's a very specific type of encephalitis that a few years ago we didn't know existed. We thought the kids that came down with that were hypersexual and mentally disturbed. It turns out they have a disease process that we can actually fix, and they have an outcome that we can actually treat. That's what comes from understanding and learning about the central nervous system. But the same way we're learning in that area, if you look at cardiac rehab, before, the outcomes in big cardiac surgery were binary. You were either alive or dead. Now that we're better at keeping people alive, we can pivot from just having binary outcomes to say, we've saved you and we've made you able to stay here in order to do what? And that what should be more than just sitting on a couch watching TV. That more should be living, being, finding, breathing, and doing things in your community and with yourself that bring you joy and give you a place and a passion.
But sitting on the couch and watching TV is so fun. Oh, it's so fun.
It's fun for a while, but we can't build a life around that. We can't build a life around that. But that's the joy of rehab, is that we help all of our colleagues in medicine that do wonderful treatments to save and provide for kids, take it to that next level. So now that you've done your job in neurosurgery, orthopedics, cardiology, family practice, internal medicine, anesthesia, whatever your gift, we take it from there to say, let's move this even further forward towards better.
I want to go back to encephalitis for a minute. Of course, swelling of the brain. How many different types are there? And then is this something that happens randomly, or as in, is it preventable?
Well, encephalitis is a general term. So there's lots of things that result in encephalitis. Some of them are infectious, like you had a viral infection that caused some swelling in your brain. Some of them are bacterial. You had a bacterial infection that caused some swelling and irritation in the brain. Some of them are in response to your immune system fighting off something else. So that'd be like a post-infectious or a post-viral process. Some of them are related to autoimmune processes similar to that. There are other things that come traumatic. So encephalitis is really a catch-all term that you can get to a lot of different ways. It's a house you can arrive at on many different streets. So our job in rehab is to work with our colleagues in neurology to understand how you got to that house and which street you took to get there. But my job in rehab is to say, now that you're here, how do we find another street to get you to better?
When it comes to spinal injuries, we hear in the news often about a chance for progress being made or actual progress being made. What kind of steps in your eyes have been taken to improve, not just, like you said, you can't undo someone's brain injury, but the hope in the future is to undo people's spinal injuries.
Correct.
How close are we to that, or is that too broad and vague to say?
You know, there's a lot of work that still has to be done in that area, but money and resources and talent are being poured into making that problem one that we counted as solved. There's great work going on through the NIH. There's great work going on through NIDA. There's great work at a lot of academic centers around the country studying spinal cord injury and injury to the central nervous system and how we can make it better. In the interim, my job is to help families and patients hope for, pray for, and focus on where they want to be, but prepare for what is. So my focus when working with a child or a family that has a spinal cord injury is to say, based on your injury, what are the kinds of things you should be able to do easily, independently? And what are the things that will be a challenge for you? I then aggressively manage the consequences of their disability, like muscle spasticity, poor muscle control, skin breakdown because they're sitting too long, other things related to circulation and your musculoskeletal and neurological system that are result from part of your central nervous system being cut off from the other parts. And put that in the context of saying, how do we get on with life? Just because you had a spinal cord injury doesn't change in any way, shape, or form your ability to be pregnant as a female. It changes slightly your ability to be potent as a male, but you still make sperm and can have children. It doesn't change in any way, shape, or form by itself your thinking abilities. So people with spinal cord injuries dream, think, be, grow, and achieve in careers as broad as there are options. Just because you have a spinal cord injury doesn't mean you can't drive. We just need to make it so you control the car with your hands and arms as opposed to with your legs and feet.
Yeah.
So all that being said, my job is to really help people see that path with their spinal cord injury, that they can still walk, metaphorically speaking, while our scientists and researchers are trying desperately to find a way to undo their original process and problem.
What are some things, and I don't know how fully developed this answer can be, just because you're really new to children's, but what kinds of things are you working on presently, and then where do you hope children's will be in the next couple of years and even in the next decade?
Great question. My job is to really help patient throughput in the system, meaning wherever you start and wherever you want to end up, there's a process in between those 2 points. We at Children's need to be there for every step in that process. So if a patient needs help in the intensive care unit, if they need help while they're on an inpatient floor, if they need help in an outpatient setting, if they need help anywhere in between there, we need to have the right services provided to the right patient at the right time for the right duration. The same way we do with a medication, we need to do that with our physical medicine rehab interventions. So that's what I'm working towards, number one. Number two, I want Children's to be a good steward of our community and a good partner with other great resources the community already has. I'm not looking to redo, replace, or compete against anyone. This is all about collegiality and collaboration, because that is the essence of rehab.
Well, I thank you for your time. I want to make sure that we get everything out that we want. Is there anything else you'd like to add that you think a lot of parents need to know about rehab services, or even other health professionals that maybe don't work in that area?
If you think rehab doesn't apply to you, you're wrong. There is something in our wheelhouse in Peace Physiatry that can help anybody be more functional. So whether you're a primary care doctor or the most super subspecialist, there's a way I can partner with you, and my hand is out to do that. If you're a parent and you don't know what to call what your child has, you don't know exactly what to do about it, you just know and hope and believe there is something, you call me and find me, because we'll find that answer together. If you're a kid out there that wants to be able to do, live, and be at the highest possible level, you find me or one of my colleagues in Peace Physiatry, and we'll partner with you to help those dreams become a reality. That's what I want to leave people with.
That's great. And we will have your information available as you provided on this podcast. We'll have it when we post the show. People can access it. They'll be able to find us at childrensmn.org. We're on Twitter at childrensmn, and we're on Facebook it's /Children's Minnesota, but we're easy to find. You can do a quick search. They have that great search.
Absolutely.
But yeah, Dr. Sholas, thank you so much for joining us, and we're excited for the work that's being done.
Hey, thanks for inviting me.